Welcome back, everyone. Today we are diving into a classic bedside maneuver that is so simple, yet so vital, it's practically a rite of passage for anyone working in an ICU or an ER. We're talking about Allen's test. Sarah, I've seen residents jump straight to the needle for an arterial blood gas without even thinking about this. It drives me crazy because it's like jumping out of a plane without checking if your backup parachute is packed.
That is a very vivid, if slightly dramatic, analogy, Dr. Khan. But you're right. From an academic and board prep perspective, the Allen's test is the gold standard for verifying arterial patency in the hand. Specifically, we are testing the efficiency of the radial and ulnar arteries and their ability to provide collateral circulation through the palmar arches. For the boards, you must remember that the hand receives a dual blood supply.
Exactly. I tell my students to think of the hand like a high-end luxury hotel with two separate power grids. You've got the radial line and the ulnar line. Most of the time, they're both humming along fine. But if I'm going to go in and mess with the radial grid, maybe by sticking a large cannula in it for a radial line, I better be 100% sure that the ulnar grid can power the whole building on its own. If it can't and the radial artery clots off, that patient is going to have some very cold, very dead fingers.
Precisely. Let's get into the high-yield anatomy. The ulnar artery typically provides the primary contribution to the superficial palmar arch, while the radial artery is the main contributor to the deep palmar arch. However, in most people, these arches are complete, meaning they anastomose. If one is blocked, the other takes over. But why does this matter clinically? Because in a small percentage of the population, those arches are incomplete. In those patients, the ulnar artery might not be able to reach the thumb or index finger if the radial artery is compromised.
And that is why we test. So walk us through the Khan and Sarah approved method of actually performing the test. I've seen people do it halfway, and a halfway Allen's test is worse than no test at all because it gives you a false sense of security.
Step 1. The patient's hands should be resting in their lap. You, the clinician, use your thumbs to firmly compress both the radial and ulnar arteries at the wrist simultaneously. Step 2. Ask the patient to tightly clench their fist. This clenching effectively squeezes the blood out of the hand. When they open their hand, and this is key, the palm should look white or blanched because you are still obstructing the inflow.
Right, it looks like a ghost hand. Now comes the moment of truth. You keep the pressure on the radial side, but release the pressure on the ulnar artery. Then you count. You're looking for that flush of pink to return to the palm. I call it the sunrise effect. If that hand turns pink within 5 to 15 seconds, you've got a positive test, meaning the ulnar artery is patent and the arch is intact. You're good to go.
Now, for the exam, keep the terminology straight. A normal or positive Allen's test means the color returns quickly. If the hand remains pale for more than 15 seconds, that is an abnormal result. Clinically, this means you should absolutely not use the radial artery in that hand for any invasive procedures. You'd have to move to the other hand or use a different site entirely.
And I can tell you from experience, taking that extra 30 seconds makes a world of difference. You know, Sarah, I had a patient last week call me his doctor of choice simply because I took the time to explain this exact process. He'd had a bad experience elsewhere where they just started poking. Patients appreciate the diligence, and it saves you from a vascular nightmare.
It's about safety and precision. Let's talk about a classic board question scenario. They might describe a patient who needs an arterial line for continuous blood pressure monitoring. They'll ask what the first step is before cannulation. The answer is almost always perform an Allen's test. They might even give you a scenario where the hand stays blanched after releasing the ulnar artery and ask what the underlying anatomical variation is.
And the answer there is an incomplete palmar arch. It's such a clean anatomical clinical correlation. Why does this matter clinically? Because if you ignore an abnormal Allen's test and the radial artery gets damaged, you're looking at digital ischemia, possible gangrene, and a very unhappy surgical consult. It's the difference between a routine ABG and a major complication.
We should also mention that the test can be reversed. If you're planning a procedure on the ulnar artery, you'd release the radial side instead to check for ulnar to radial collateralization. It's all about the patency of that arch system.
Exactly. It's the backup generator for the hand. If the backup isn't working, don't cut the main power. It's a simple rule for a complex limb.
To summarize for our listeners, the Allen's test verifies that if one of the two main arteries to the hand, radial or ulnar, is compromised, the other can maintain sufficient blood flow via the palmar arches. To perform it, compress both arteries, have the patient clench their fist until blanched, and then release one artery to observe the return of color within 15 seconds.
Beautifully put. Next time you're about to draw an ABG, remember, check the parachute first. Pink is good, pale is a problem. See you next time.